Hi everyone, we're just waiting a few seconds for people to join and then we'll kick off. So please bear with us. Okay, we have some slight technical problems with one of our speakers, which we're trying to sort out. So just bear with us. Okay, I think we're going to make a start. So thanks everyone for joining us today at this webinar. Just a little bit of housekeeping before we kick off. So I'm Duleep Allrajah, I'm chairing the session. I'm the CEO of the Richmond Group of Charities. The format we're taking is we'll have a few very short presentations, but we've allowed a lot of time for Q&A. So please feel free to post questions during the presentations or after. We've switched off the chat, so we're only using the Q&A function. So please post questions using the Q&A function and we'll answer as many as we can in the allotted time. So the Richmond Group of Charities is a coalition of 15 national health charities. We've recently published this new report on neighbourhood health, which we're very excited about, putting people at the centre, making neighbourhood health work for people with multiple conditions. What we want to do today is to really bring the learning from the report to life. It's based on a number of case studies. So we're going to hear from some of the case studies today. And the purpose of the report really is to demonstrate how you can redesign care around the needs of people in practice. It has a very practical application. Neighbourhood health is something that everyone seems to get excited about and agree with, though if you put 6 people in a room, you'll probably get 6 different definitions of what neighbourhood health means. We don't think it can solve all the problems of the NHS, but it can really make a difference to people with long-term and multiple conditions, and that's what we want to explore today. What the report shows is how you can create in practice a joined up service that's proactive, equitable, designed around people and can be delivered in neighbourhoods. So it provides the report provides a lot of practical steps that local leaders can take now. So we've got 3 speakers. We've also got Beth Colliety who's our policy manager, who led on the report and is going to open with a short outline of what the report's findings are. But we've got a great panel of speakers. We've got Nick Gitsham, who's the strategic lead for the National Neighbourhood Health Implementation Programme at NHS England. We've got Alexis Kolodziej, who is the Deputy CEO and Executive Director for Influencing and Research at the Stroke Association. We've got Abdul Razaq, who is Director of Public Health at Blackburn with Darwen Council. So I'm going to hand over to Beth to kick off. We'll then hopefully hear from Nick and our other speakers. So Beth, do you want to lead off on what you found in the report?
I will do. Thanks so much for joining us today, everyone. Really good to see you all. So I'm going to give a short overview of the report and its key findings. So firstly, why did we take a multiple long-term conditions lens to this report? 1 in 4 of us live with multiple long-term conditions and the number's rising. It's very much becoming the new norm. Our past research into the experiences of people living with multiple conditions found common problems, with fragmented care delivered in biomedical silos, people being overwhelmed by the administrative work of being a patient, unmet social needs, and not enough focus on what matters to the person. We therefore think people living with multiple conditions have the most to gain from more person-centred, preventative neighbourhood health services in their communities. So based on those common challenges faced by people living with multiple conditions, we developed these 5 tests for neighbourhood health, which can help to assess whether these challenges are being addressed. Firstly, proactive, not waiting for things to go wrong and getting to crisis point, but actively anticipating crisis and supporting people to stay well. Coordinated, services and professionals talking to each other and reducing the administrative burden on the patient. Cross-sectoral and holistic, bringing together the strengths of clinical and community support to address a problem holistically. Equitable, focused on the needs of people not well supported by existing models, reducing discrepancies of access, experience and outcomes, and building trust. And lastly, person-centred, responding to what matters to people, which in practice is most likely to be a combination of clinical and non-clinical concerns. The report uses 12 real-world examples to show how local system leaders can bake elements of our 5 key tests into neighbourhood health. You'll hear from 2 of these great case studies today. The report's got several recommendations for local leaders on how they can deliver this kind of care in practice, and how national leaders can unlock those barriers to being able to do that. So firstly, proactive. The key messages that local areas had for us and the commonalities we saw in practice were to use the best data you have available, as it's not always possible to get hold of meaningful data sets and risk stratification tools. For example, a GP practice in Slough visited homes who hadn't engaged with routine health checks and appointments for screening and vaccination. Start with a defined and manageable cohort, which in practice is going to be driven by practical considerations about resource. We saw that non-clinical staff had a key role to play in identifying those who would benefit from more proactive care and conducting that first tier of outreach, which enabled clinicians to focus on those in greatest need of their direct support. And in the examples we looked at, small-scale additional resource can catalyse action, with social investment presenting a positive solution, a possible solution. The next test around being coordinated. We saw that data sharing was quite a key barrier to care coordination in a lot of the places we spoke to, and we make suggestions in the report about how national action can help to address those data sharing barriers. And we saw that non-clinical staff were playing a role in coordination and continuity for people. To maximise that contribution, non-clinical staff needed to be valued and embedded as part of the integrated neighbourhood teams, being given parity of steam with clinicians and being factored into national and local workforce planning. But poor coordination evidently happens in all sectors, and models of coordination beyond the NHS need to be resourced as well. Cross-sectoral and holistic. So we saw here that unpacking how to build strong relationships is so important. We saw that you need to build connection organically. So start with a relationship you have and travel along that person's relationships to build out and go bigger. Invest in connection. This means valuing and funding the contribution of people, organisations and infrastructure that are good at connecting, and those places and spaces where you see connection happening. You've also got to commission for connection. We've seen that short-term contracts and ongoing national reforms are impacting relationships that obviously take time to build. And areas also recruited staff who understood how to connect and who brought connections from their community. I've spoken about non-clinical perspectives, so those teams that were the furthest along were valuing the perspectives of non-clinical individuals, so social workers, VCSE staff, peer supporters, unpaid carers, and people themselves. Governance and risk management is undoubtedly important here, so all partners in an integrated neighbourhood team have to work together to define a shared approach and think about how they can hold risk together. Equitable. Few of the places we spoke to were routinely collecting the data they needed to properly understand their impact on health equity. But they used the data they did have to target those most in need. For example, 20% of the most deprived households within a neighbourhood. The most promising practice we saw around health equity used the NHS's data set and reach to identify those who might need specific support, in combination with the creativity and flexibility of the VCSE sector to provide that more personalised response to people where they were. So partnership work is important to pull insights on unmet need and use organisations that people already know and trust. And we saw that incentives are often misaligned around this, so output targets can encourage a focus on those who are easiest to reach. And I think it's important here to be cautious around overloading the neighbourhood health agenda and only focusing on areas like hospital activity. As Duleep mentioned, neighbourhood health can't solve all the problems facing the NHS overnight, but it evidently can make a difference to those people experiencing the most disadvantage in practice. So the last test, person-centred. Teams were really clear that getting eye to eye with communities required a mindset shift that takes time. It's not only about the needs of an individual, but shaping support with communities. Time devoted to supporting someone's self-management efforts paid off in practice in terms of developing that person's skills and capacity to better manage their own health in the long term. But the community organisations providing this information and support are under significant pressure. We have to think about non-transactional commissioning and funding models that don't impede the ability to work flexibly with people. So we've got to keep roles flexible to support the person and what they need at that point in time. This evidently creates challenges to traditional professional boundaries and statutory services, but we've got some great examples in the report of how this happened. Also around being person-centred, measure what matters to people rather than the system alone. So patient-reported outcome measures and ways of capturing whether services delivered on the priorities people have set themselves have to be used to determine whether neighbourhood health services are working. Ultimately, what would I like you to take away? We need to put people at the centre and design care about what they need and want, measuring the success of new neighbourhood health approaches against that. Neighbourhood teams have got to be cross-sector, so bringing together all the agencies involved in a person's life: health, social care, the voluntary sector, housing, other agencies, to really combine those different assets and work holistically. Local areas have got to look beyond the NHS and traditional clinical roles to valuing and investing in non-clinical roles in the voluntary sector. In our research, we saw that non-clinical roles like care coordinators, community health and wellbeing workers, health coaches have more time to address the interaction between social and clinical needs, are better at tackling inequity and helping people regain agency over their own health. So thank you. I'll now pass back to Duleep.
Thank you, Beth. I'm going to hand over now to Nick Gitsham, who's strategic lead from NHS England's National Neighbourhood Health Implementation Programme. I'm really pleased to have Nick here, and hopefully all the tech problems have been sorted out. So Nick's going to speak for a couple of minutes just to give you the national perspective from the programme.
Hi everyone, and fantastic to be here this morning. We have had a few tech problems, so I'm quite relieved at this point. Whether we use the slides or not, Duleep, I might just share them afterwards and actually give some messages. I think that might be better. But I think the first thing I wanted to say was I really want to welcome this report. I think it's an excellent piece of work. And for me, it really spells out what's at the heart of the change that we're trying to achieve with neighbourhood health. You know, I think what it does is it really talks about how we can empower people and communities and not just shift the activity from hospital to community. It's about how we actually work with people. That is so critical. And so really welcome this report. I think it's got some excellent high-level messages. We've talked about the 5 key changes that are critical, Beth, to being embedded in neighbourhood health. And I just think it gives some really practical suggestions. So if anybody implementing neighbourhood health uses these 5 principles, then I think we will improve the delivery of neighbourhood health on the ground, definitely. It was brilliant to see some of the examples coming from the National Neighbourhood Health Implementation Programme. So obviously we have now the Neighbourhood Health Framework that was published in March. And we've also had some key documents on neighbourhood health centres and also some of the different contracts. You've got the consultation out for single neighbourhood and multi-neighbourhood contracts. And I think, you know, we've got some really key messages in there about how we work differently together to enable people to have true independent living, so they have choice and control over their lives and the way they're supported. And we really empower the assets that people bring, the sort of the things that people bring to be able to help them manage their health and well-being, and also for communities to be healthy places to live and work in, and how we can really bring those things together. So we've got the framework. And we know that at the heart of neighbourhood health, we're really talking about that proactive, preventative approach, a person-centred approach that really focuses on what matters to people, a holistic approach that looks at people's social needs, their psychological needs, and tries to bring that together in a joined up offer across agencies much closer to home. And we know that's important for many, many people, but particularly important for people with multiple long-term conditions. So in the National Neighbourhood Health Implementation Programme, we're currently working with 43 places around the country and their systems. And what those areas are doing is they are really bringing together a coalition for change locally. So people across all different elements of health, across social care, across wider elements of local authority like housing and employment, and importantly with the voluntary sector. So we've heard consistently that the voluntary sector partners and the charities that you're working with through the Richmond Group are absolutely critical to being able to realise neighbourhood health on the ground, because for many, many reasons, but one, because you often have the soft intelligence that's not in the hard data that comes through in population health management. And it's so important that we use the community insights as well as the hard data when we're understanding who's most in need in a local population and being able to proactively reach out. But also because the person-centred working, the being able to really have the time to listen to people and understand what matters to them and connect them to community health and well-being activities or offers such as green activities or arts or nature or social welfare support is so critical to being able to really understand the many reasons that are affecting people's health and are actually can be managed in a much more proactive way. And not only is that good for people, but what we're seeing consistently throughout the programme is that it reduces pressure on many parts of the system. And so that interagency working and working with the VCSE in a person-centred way is absolutely critical. So I was just sort of thinking some of the proactive work that we've seen some great work in Walsall where they've got Feel Good Friday clinics for people who are have frailty or at risk of frailty and at risk of deterioration. And they've been working with their voluntary sector partners and also community pharmacy to really be able to reduce people's medications when they're on medication that isn't helpful for them, but also to reduce that risk of polypharmacy and support people by looking at the more holistic issues, whether it's housing or loneliness that's driving some of the demands on services. Coordination, great with care coordination and integrated neighbourhood teams. Cross-sector holistic, yes, we've seen the fantastic work of the community health and wellbeing workers who also help with that equitable element of being able to really get to know areas of where people live in areas of deprivation and take that whole family approach and knock on doors to really understand how people are accessing the NHS and other social welfare offers to improve their health and their access to services. And then person-centred, I would just pull out Cornwall and the Isles of Scilly. I've seen a really good understanding of what it takes, one, to really get a sustainable offer for VCSE services, but also to train all staff in personalised care and support planning, so that we're not just talking about treatment plans, we are really talking about a person-centred plan that identifies what matters to you and has a holistic approach and brings that broader integrated neighbourhood team of housing, social prescribing link workers, and employment, and everybody around the table to really help people live independent lives in their communities, focused on what matters to them. So just in summary, I would say I'd really encourage people to share this report widely. We will certainly be sharing it with policy colleagues, but also through the programme, and also to join the movement. I think, you know, I've worked on personalisation for probably over 30 years now, and we've seen some really fantastic work. But there is still huge variation. And when we listen to people and we listen to their families, we know they don't get a person-centred, proactive, joined up offer of support to help them manage their health and well-being in a way that matters to them, as close to their homes as possible. So we have much to do, and really welcome this from the Richmond group, and thank you for all the work that you've been doing as a group of charities, and really encourage people to get these champions and allies across the country.
Great, thanks a lot, Nick. And lots there to unpack. I think there's some really good stuff going on in the sites that Nick's team is supporting. We don't always know about them, and I think there's a job to be done turning some of those stories into a narrative about how you make change. I'm going to hand over to Alexis from the Stroke Association to talk about their stroke support services, which are designed to help people who've had a stroke get their lives back and recover afterwards. And these services are commissioned by the NHS or local authorities across the UK. So Alexis is going to talk for 3 minutes about stroke support services.
Thanks, Duleep, and thanks to the Richmond group for the invitation to speak today, and for the report that I think really gets to the heart of the opportunity here. As Beth said, neighbourhood health really will only work if we truly design it around people's lives rather than just relocating services, existing services closer to home. So stroke is a really good example of why this matters. A stroke is a medical emergency, but recovery is long, and it's very rarely a linear process. When someone leaves hospital following a stroke, they're really likely to have problems with mobility, communication, post-stroke fatigue, anxiety, changes in identity and relationships. Often for kind of working age stroke survivors, there'll be money or potentially housing worries, and often other health conditions as well. None of this arrives in kind of neat organizational boxes. You know, worries about benefits, housing, or returning to work absolutely make it harder for someone to engage and concentrate on their therapy. Communication difficulties can make accessing services really tricky. I've heard from community stroke rehabilitation teams, for example, that it's not unusual to attend someone's home to provide therapy, to find that there's such an unstable and potentially unsafe living situation that providing that important rehabilitation therapy is just simply impossible. And neighbourhood health could be a great solution to that, but it depends on having more role flexibility, as mentioned, not seeing kind of role boundaries as impenetrable, much better multi-agency working, and the ability for any health professional or someone who's involved in the provision of health and social care in the most general terms to be able to respond in the moment to the wide array of needs that an individual might have, seeing the whole picture of their living situation and not just the part of what that person's service is there to provide. Because ultimately, if we're looking at things through the lens of the service and what that particular service provides, then all we're doing is placing the burden of care coordination with the person who's already very unwell. So as Duleep says, we have stroke support coordinators across the whole of the UK, not commissioned in every area, but in many areas. And they're an example of a role that can help join pieces back together. They listen to what matters to the person and their family. They agree a plan. They connect them to clinical, practical, emotional, and peer support, and they stay alongside that person as their needs change. We're seeing pretty big numbers of people. So last year we saw 38,000 new stroke survivors, but 66,000 stroke survivors overall. And We think that the value in our staff is not just the individual support they provide, which we know is really well evaluated, but also we know that done well, their role makes the wider system work better too. So our coordinators provide continuity across the transition from hospital to home. They bring into a multidisciplinary team a picture of what's actually happening in someone's day-to-day life. So they can identify barriers which might stop someone engaging with their rehab. They connect to services which would otherwise work separately. And they reduce the need for repeated assessments and the need for people to tell their story again. And crucially to the system, they help clinical colleagues focus their time on where their expertise adds the most value. So one of the case studies that was included in the report was our service in Bath and Northeast Somerset, where our coordinators are full members of a multidisciplinary team. They can see and contribute to the same patient information, for example, and that really changes the model from one of just referral and signposting to one of really genuinely shared responsibility for that person's recovery. And this isn't our only service that operates this way. Our services work best where they are embedded in that team, multidisciplinary team approach. But there's lots of different models for how that happens over the country. There's some who might just be kind of attending board or ward rounds, all the way through to kind of weekly MDT team meetings as well. So I think our kind of challenge to local systems is that we shouldn't be designing the neighborhood team and then asking where the voluntary sector can plug in. It would be great if we could see all systems starting with the person and then building a cross-sector team around them. One of the other things that we've seen in neighborhood health and lots of initiatives before this is that there's an assumption that kind of one often small local organization can play the role of representing the full complexity and variety of the voluntary sector, and that just doesn't work in practice. Often, as it is the case with the Stroke Association and many other charities, our value is that we're plugged into distinct clinical pathways. So effective involvement needs to take note of that and provide multiple opportunities for involvement that gives non-clinical roles real parity of esteem, access to the right information, and a clear place in the decision-making, as well as access to sustainable funding. Because, you know, the prize isn't just kind of more activity in the community, it's a true pathway with more coordinated, more equitable support that's better able to help people recover and manage their health and live well. I'll finish there, Duleep, and pass back over to you.
Thank you so much, Alexis. Really good example, bringing to life a lot of what we've talked about in the report. I'm going to hand over now to Abdul, who is Director of Public Health at Blackburn with Darwen. And Blackburn with Darwen have built a powerful alliance of organisations that straddle health, local authority, the physical activity sector and community groups. And the aim is there to get people moving more. And what's really kind of transformational is the fact that we're talking about a non-clinical intervention to help people manage their health problems. And that was a theme that we saw time and again as we spoke to case studies in the report. So Abdul, over to you.
Thank you very much, Duleep, and a very good afternoon. Thank you so much, really, for the invitation to speak, and great to be with my fellow speakers, really. So the premise, really, of prevention actually starts, really, with directors of public health and their teams, really, working across systems to actually improve the public's health, really, and prevention, really, and neighbourhood health, really, actually are at the heart of everything that we actually then are actually here to do. We do that through a number of ways and mechanisms. Collaboration, partnership is key. Relationship management is another. Systems actually working together and actually joining up the dots from a very complex landscape is another part of some of that proactive care, really, that Beth actually talked about, and we actually heard from Nick and Alexis as well. So in terms of the mantra within Blackburn and Darwen, we're the 8th most, according to the IMD, most deprived local authority in the whole of England. We are also subject to extensive lockdowns during the COVID period. So we've taken the approach, really, that we are a trauma-informed practice borough, and so we have a lot of our work which is actually embedded within frontline staff, actually dealing with compassion, kindness, as the fundamental levers for dealing with some of the challenges that we actually face on the actual front line. So from a public health perspective, it's a very simple mission. The mission really is to save lives, to improve our lives of our communities, and to actually protect them. So it's save, improve, and protect. And how we do that really is very much really through a number of ways. Really, but I commission a number of services, including our health and wellbeing service, which is our refresh service. And as part of that, there's something called TAF, which is Together and Active Futures. What we do there really is actually put people at the centre of the of our services really. So it's very much about how we empower, how we actually then get those citizens really actually driving forward through our community and voluntary sector, which is very proactive here in Blackburn and Darwen. It has an asset base of around 14 million in terms of its kind of charitable sector, in terms of its kind of physical asset base, its resources and grants, as well as its personnel, working alongside us to actually change and transform, as well as actually provide good quality conversations. So what we're doing really ultimately is actually changing people to actually change the system, rather than the system actually changing, you know, which is the other way around really. So ultimately it's very much about systems, behaviours and places and people. As part of that model, we have a family model within our children and young people services in terms of family hubs. We have a vibrant community and voluntary sectors with our community centres, and we are really driven by our leadership really for within communities and neighbourhoods, and builds on some of the great work really that local authorities actually do at place and neighbourhood level. Next slide, please, Beth. So some specific examples really around bringing some of this to life, really. Two specific examples and a third really, which I want to actually highlight this afternoon really. The first is really around We Are Undefeatable. This is obviously a national campaign, but we've actually taken it, you know, in terms of our storytelling kind of perspective really, in terms of local storytellers actually telling their story really with a range of multiple conditions, long-term conditions, and some of these storytellers are actually well known to communities. And what this has actually done really is actually reached a whole range of our communities really, from diverse and non-diverse backgrounds, and reached brand recognition in terms of being able to be relatable to local people. We've had 15 community providers which are funded really around targeted physical activity and opportunities around those long-term health conditions, to actually remove the stigma and barriers to access around physical activity and actually get people actually moving. It clearly fits with our frailty work and some of our clinical work really as well around long-term conditions, and obviously now with the cardiovascular modern service framework as well. And now that brings me on really to another campaign that we've actually run across Lancashire called Healthy Hearts. So this has really been about lived experience and around local representation. It's actually using real Lancashire residents around physical activity options, around some of that messaging. Their stories have actually built trust and spark peer-to-peer conversation in families, communities, faith settings and wider workplaces, and extending beyond traditional forms of where social media could actually reach. And the benefits for the local system have actually been pride, stronger engagement, greater willingness to actually amplify those messages. And ultimately it's about lived experiences, and that storytelling has actually generated new ideas, referral pathways and patient activations, strengthening confidence of our local communities to actually work differently within the neighbourhood health approach. And one final, Duleep, if I may, really, is from March of this year, we are strengthening our work around This Girl Can in terms of our gender equality work around with Sports England, and to make sure really that we are following this success really from building upon We Are Undefeatable and Healthy Hearts into a broader reach for our local communities. And I'll pause there and hand back to you. Thank you.
And fantastic. Thank you, Abdul. I understand that not everyone was able to see the slides, so I think if you haven't been able to see the slides, I think we can send these out afterwards. Three really good presentations there. We're now going to move into the Q&A. I can't, if people have got questions please put them into the Q&A, and I will try to take as many as possible. I've got a question here which is probably for Nick, which is one that I think we're all wondering, which is what next? What's the future of the National Neighbourhood Health Implementation Programme? So Nick, if
of the programme.
Yes.
So, I mean, as you highlighted, we've got a lot of learning and we've got some good materials that have been developed now. We've got a maturity framework that's been developed with the systems and the sites and partners within those sites. We've got some useful guides on data, digital, and the integrator role that's often at a place level. So we're looking to share those and get those out to people as soon as possible. And then really, Duleep, we're looking at what comes next in terms of, obviously, INHIP was around 43 places, and I think they've been real catalysts within their systems. But we've got the neighbourhood health framework now. We need to make sure that it works for everyone everywhere. And so we need to be moving from one place to all places. So we're currently looking at what needs to come next that would support local areas around the country to really accelerate neighbourhood health and to use it to improve population health, but also importantly address the health inequalities in our communities. So we'll be particularly looking at how we can gather some of the best practice from areas in that area as well. So that's sort of work in progress, but up until the end of October, we are working really closely with the 43 sites. We're distilling the learning, helping them make some progress. They've got some clusters around 5 high impact areas that we've been asked to look at up to October. So we're having a deep dive around outpatients, around cardiovascular and metabolic disease, around frailty, around the provider development and interface between primary and secondary care. And so we are sort of going to be doing a deep dive on those. All of those will come out with blueprints of what the sites actually did, what they learned, any top tips for other areas. So we're currently looking at how we can improve the knowledge management on the programme to get that information out.
Great, thanks, Nick. I'm just going to fire a couple of questions at specific panelists. So, Alexis, one for you. You talked about the stroke coordinators sometimes being in multidisciplinary teams and sometimes not. Can you tell us a little bit more about what the kind of dynamics and the barriers were to these kind of roles being seen as kind of equal and valued parts of what are essentially often clinical teams?
Yeah, happy to. I mean, I think the main point is that the setup of each team varies significantly, and that's because many of them were built up over time, and often, you know, they depend on local relationships. So, and we want to not be competitive with the NHS, so they kind of do mold to kind of what the distinct pathway and patient needs are, which obviously creates a barrier in and of itself because it just takes time to understand those and then make sure that you're working with them. I think the biggest barrier is inequitable funding. Like we fundamentally we don't have care coordination in every place we need it, because at the moment our commissioning model is around commission funding, and sometimes that just isn't possible. The other barrier, though, is even in areas where we are funded, there's a barrier around insufficient funding. So in many areas, contract values have stayed exactly the same despite massive increases in demand in both case complexity. So kind of the myriad of problems someone might be living with takes more time for a coordinator to deal with those problems, and in the increase in stroke incidence. So there's more cases and more complex cases for the same amount of funding, and that just means that frontline staff are then pulled from kind of the provision of direct support into and have less time for the kind of relationship building and kind of making sure there's really smooth kind of multi-team working and kind of referral pathways. And then the final two, I think, are ones that we probably hear of a bit more, which is around the kind of cultural barrier. So there are areas where there's been active resistance to charities kind of being embedded in the team, not seeing the value that the kind of non-clinical role can bring, not seeing it kind of as central to recovery, and that having to start again as staff rotate in and out of clinical teams. So, you know, community teams often have 6-month placements. So every 6 months, the teams are kind of reestablishing the relationship, trying to prove the value of the clinical team, et cetera, or kind of, you know, having to rebuild that relationship, which ultimately doesn't put the patient at the center. And then the problems with data sharing, I mean, that could be an entire webinar in and of itself. We've just gone through a long process of getting our Stroke Association emails accredited to the NHS standard so that we could get data passed to us. But even still, with that, there's still it doesn't take away from the need to kind of have really great relationships with not just the clinical team, but their data sharing infrastructure, because sometimes even the NHS emails don't meet their own accreditation standards. So there's just lots of different problems at each area, and kind of how we've ended up kind of working around them is distinct to the individual service. So it just comes back to making sure that we're kind of focusing on the relationships with the clinical team and trying to put the patient at the very center. And we find that areas where they already have that really strong clinical leadership and they're already putting the patient at the center, it's just much easier. So it just unfortunately creates a bit of inequity for places that were not funded, that doesn't have strong clinical leadership, and the care is worse. It's a bit of a self-fulfilling prophecy. I hope I answered that question there.
Yeah, no, that's a great answer. And I think what we've tried to do with this report is say it's possible to make change happen, even if you haven't fixed all of the other issues like funding flows, but actually data and funding are very important enablers that are often outside the gift of local system or local kind of practitioners. And I think that was a key message that came out of this for us, for policymakers. I'm going to pitch a question to Abdul. You've built a kind of an alliance really of different parts of the system that don't traditionally work together. So I just wanted to get your perspective on how you did that. How did you build the trust, and how did you get these different elements of the system who don't normally work together to start operating together?
Yeah, thanks, Duleep. The essence of the actual partnership has been, the foundations really are based upon a process really whereby we've got more socially minded, non-medical, biomedical clinicians really, who actually see the value of prevention at the heart of everything really. So in Blackburn and Darwen, we actually have 4 integrated neighbourhood teams, INTs, through an MDT approach, and we've got social prescribers and we've got community connectors as part of that process, who are actually embedded within that MDT, and are able then to actually work alongside the neighbour teams and the clinicians around some of those cases. So they're actually an embedded part of the actual core as part of that kind of clinical pathway, so to speak, and take on responsibilities for having those conversations, for taking that work forward really in that way, in that holistic way. And a lot of that model really around basically how we actually work with communities. Blackburn and Darwen generally has a community network through our community or voluntary sector, and people and places really are a pivotal part of the principles by which we actually work locally. So I think it's very much, and the collaborations really have actually been strengthened as a result of the resilience that we actually showed as a community here in Blackburn and Darwen during the COVID period, and we've sustained that relationship because we're compact enough with 165,000 residents that we serve to be able to, so it's size, but a lot of it really is built upon good, strong, continual relationships, and we never let money actually, kind of get in the way. What we try to do really is try to actually commission to the best of our abilities in a joined up way. And secondly, really, a lot of it really is by bringing investment in, which actually brings, kind of benefit to local communities. So as an example, the RICB has been pivotal in actually providing local grassroots organisations with funding for mental health issues, for cancer champions around the Macmillan Nurse kind of aspect. So a lot of this really is about how we actually utilise some of the strategic commissioning to better effect for local communities as well. We also have done a lot of work around population health management in the traditional and non-traditional sense, where we've used something called the PLACE tool, which has been developed by colleagues up in Scotland for our central parts of Blackburn, which are a very diverse set of communities, and we've used that to actually leverage in additional resource to have conversations with our local communities around empowerment and regeneration. The other aspect really is that we are levelling up. I know it's not usually a term that we use anymore as we move into a devolution agenda, but local authorities do actually have resources around revitalisation of communities. Pride in Place is another example which needs to be tied in really with neighbourhood health. I see Nick nodding.
Yeah.
So a lot of it really is very much about joining up existing government programmes to better effect for local communities. And Pride in Place as an example, that investment is 20 million over 10 years really, and that's really grassroots up. It's not really about statutory organisations, it's actually about how communities themselves really can actually develop solutions and empower themselves really to actually find it's to actually improve overall health and well-being from within their asset resource base. And how statutory organisation can work alongside those communities to empower them to actually deliver the best health and well-being for them. So I think that there's lots of opportunities really to actually join up the existing funding streams, and we mustn't let data or funding actually get in the way, because basically we may never solve that in its entirety. We've got to do things really where because in my 3 decades, colleagues, really, and more in public health, those two things do come up really, but let's not think really that they are the ultimate test. They help, but we've got to do things really where basically the intelligence and the people really are at the heart really, and they're enablers, but let's not get too drawn into when will data actually all flow in one system, which benefits everyone really, because that's the shared care record. And clearly in some areas really that does actually happen better than in some other areas. So yes, there are some examples really where it can make it better, but the best intelligence that we can actually get really usually is what people actually think, and it's about lived experience really, and how people actually feel, and that won't be found necessarily within a clinical record in the traditional sense. So we do need to think about how we use qualitative data better as part of this neighbourhood health kind of initiative. Thank you.
Thanks, Abdul. Having said that, we'll try and answer all your questions. There are now so many questions and only 10 minutes left that we're not going to be able to answer all your questions. So what I'm going to do is there's a question here which I've been meaning to ask, which I'll try to answer and link to another question. So there was a question which says, was there anything surprising or unexpected in the process of publishing the report? I think before we started speaking to these case studies, we didn't really appreciate the value of non-clinical roles. I mean, we knew they're important, but that came through as a much stronger theme than we had expected in the report. And so linking this back to a sort of wider question, which is something Alexis touched on, is non-clinical roles. I mean, the non-clinical roles can make a little bit of funding go a very long way, and that's one of the reasons why they're important. They also, unlike clinicians, are able, people have the time to spend with the beneficiaries of the service and really understand what's at the root of their health crisis in a way that clinicians really can't. With the best will in the world, they might have the skills, but they are absolutely flat out. So that non-clinical roles have a really important role to play, but they are not always valued. So there's I'm going back to the cultural question that Alexis raised, and this might be for you, Nick, and maybe for Alexis, which is how do we change the culture so that in a system that is very clinically dominated, we start to get clinicians to really understand how non-clinical roles can support them and work with them.
Shall I kick off? Just a couple of observations. I think the first thing is, I always say, what's the problem you're trying to solve? And if we only focus on what's wrong with you, then we get very medical solutions. If we really focus on what matters to you and what are some of the root causes that are driving inequality and are making people's health and well-being poorer than it could be and giving people shorter healthy life expectancy, then I think we get a much better understanding of the problem. So when I see population health management approaches that include some of these social and economic issues and working with the local authorities and the public health colleagues to really get that broader understanding of health, then once you understand what the problems are, then you have to create a team that is much broader and has these non-clinical roles in it that tackles the social, the welfare, and the community connecting and care coordination and supported self-management. So I think that's one thing. I think the second thing is where people have used them, I think it's really sort of making sure that we're all working together to really understand the priorities and lean into those. So it's not just these roles doing what they think might be interesting on the side, it's actually being part of the solution in a local area. And once people see that, they see that proactive outreach, and we've got the evidence, we've got so much evidence now on social prescribing to demonstrate the impact on people and reduction on services. We've got it with Chewies, we see it with lots of other roles. Then I think once they see them working in that way, they don't like to let them go from their teams. But I think we have really got to look at sustainability of funding for them, because they have to be seen as part of the solution. We've seen ours funding stick on these roles for the last X years, and that's not going to get us to where we need to get to. And we are seeing some interesting innovative approaches like South and West Herts with their partnership with Macmillan, where they've got the social investment funds going in to look at a bigger pool of funding to help with health and wellbeing activities. But I think really understanding what the population needs, really leaning in together to solve them, and then looking at how you give that common supervision, support, training. It's ridiculous that we don't get that combined effort of these types of roles across local authority, health, public sector. Yeah. Just a few sort of thoughts at the top of my head. Alexis, what do you think?
Yeah, I mean, I love all of that, Nicola. I think that's such a great start. And yeah, starting with the problem that you're trying to solve. I think the things I would add from a stroke perspective is for, I think clinical teams need to understand the world of the charity sector, and charity sector needs to understand the world of the clinical teams. So just a really specific example, I've lost track of the number of times I've heard acute stroke teams say something like, oh, we want to make a peer support group and we're really struggling to understand how to do this, or we can't find a room for the support group that we had. And I think that's great in one sense because they're spotting a patient need that's real and they're trying to fill that. But it's a shame because they're not looking at who else could support them with that. So the charity sector, Stroke Association, like most other health charities, are experts in peer support and convening and kind of looking at community assets and bringing people together. And actually, if they just stopped and said, okay, here's the problem, look up, look out, who can help us with this and be part of a joint solution, how much more sustainable and brilliant those groups could be. Now, I think the charity sector also has to do that as well, right? We sometimes are, it's the same point that Beth made in the report, that we need to look at that as well, because how much better could our peer support groups be if we linked it with a physio or we linked it with someone in the system? So I think there's, for both of us, we need to look up and out and look at each other's worlds and see what else is out there. And just to, if I have 2 seconds, I'll bring in another example. So it's looking at the value of the charity sector as a convener as well as a provider. Yes. So we have a project in Stoke that works with Stoke City Football Club to connect stroke survivors with a physio. It uses the Stoke City's gym and it's now sustainable. It's self-funding. So we put a tiny little bit of funding in, convening power, got the kind of the physios working together. Now it sees, I don't know the numbers, but they've got brilliant throughput of stroke survivors with brilliant outcomes using assets from the community, from the NHS that are already there, bringing the best of both things, putting them in. And we haven't Stroke Association provided. We've just kind of linked up those assets together, and it's become brilliant for that local system. It's something we're trying to replicate in other places. So I think there are some really great examples out there that push boundaries. It's just about finding them and highlighting them and making sure people know they are able to be replicated.
And I think, Alexis, you make a really good point, because it's actually getting to understand what each other can bring.
Yeah.
And it's building up that trust. I think so I saw a fantastic example in Cambridge and Peterborough the other day, where they focused on young people and their families, where young people are kind of stuck on the community waiting list for neurodiversity referrals. And they did a fantastic sort of event with the voluntary sector, charity sector, and clinicians and all sorts of people coming together to for families to see what sort of support there was in an area, and how for many people getting that support while they were waiting was absolutely critical, but also help them solve certain problems earlier for some people. So I think what we see across the National Neighbourhood Health Implementation Programme consistently is that importance of building trust and relationships in interagency teams and clinical and non-clinical roles. That is so important. It sounds such a soft issue, but having that shared understanding of the problem, shared understanding of what good looks like, coming together to use our skills, trying it out, and building that trust and confidence that we can trust colleagues, reduces unnecessary referrals and just gets that networking working better. And that's so important. But we can't only do that. We have to have the voice of people and their communities as part of the solution as well. And that's really, really critical. But yeah, trust and relationships is a foundational step.
And I think that's what's really important here, is that you can't just parachute new roles into systems. You need to put a bit of change management around it so that people are taken, because if you have a social prescriber or a care coordinator, it means that the role of the GP or the nurse, community nurse or whatever is going to change. So you need to take people on a journey and get them to buy into the change and work through together how they're going to how the new multidisciplinary approach will work. We could go on for another hour very easily, but we've run out of time. What I'm going to do is just ask each panelist for their one takeaway for 30 seconds each, and then we're going to have to wrap up. So I'm going to start with Abdul. 30 seconds. I'm going to be very strict, and then Alexis, then Nick, and then Beth, if you want a final say. So, Abdul, what's your one takeaway?
My takeaway really is lead with humility, courage, bravery, kindness, and compassion.
Thank you.
That's a brilliant one.
Beat that, Alexis.
Yeah, I know, right? I think so. I mean, in addition to that, I would add there is so much good stuff out there. So kind of invest time in finding out what there is in your community to build from, including the voluntary community sector, obviously, but look broad and wide for your partners and your advocates in building your neighborhood health.
Great. And Nick?
They're all fantastic. I would just say be really curious. Every time I work with colleagues from different teams or different perspectives, like even, Alexis, with you, I didn't know what the Stroke Association was doing. It's fantastic. And Abdul, just brilliant to know more about what you're doing up in Bradford and Craven. So I think in your area, so for me, it's like being really, to get good partnership working, we have to really understand from each other's perspective what matters to you, what are the things that really matter to you, and what can you bring, and how could we put that together? And that starts with us all having a shared understanding of listening to people and their communities about what really matters to them. And I was really pleased, Abdul, you brought in Pride in Place as well, because that's such an important thing to align with, and those sorts of things. Because I think neighbourhood health, we often think of it as health, but I think it is health in its broadest sense, but also this is about changing the way all public services work, whether it's employment, housing, or whatever. And if you look at the work in Greater Manchester, say with Live Well, that's what they've been really trying to rewire in local communities. So yeah, stay curious.
Great. And Beth, did you have a final takeaway? Oops, can't hear you.
Beth, you're on mute.
Sorry, in speaking to areas throughout this, we saw the difficulty. We saw, you know, the issues with demand, the underfunding of primary and community services, and that the workforce is already quite stretched. But I think the positive thing is we saw people who are making this change happen. And just thank you to all those areas who spoke to us. I definitely would encourage you to read the report.
Great, thank you. I couldn't have put it better. I think we've basically given you a flavour of what's in the report, but please read it. Please talk to us if you're interested in working with us. And obviously the Neighbourhood Health programme itself is working with some fantastic inspirational sites. So be curious, as Nick says, and find out what they're doing, because how we change is there's enough out there to give you a template for how to do it. It's just you need to find it, and you need to understand it, you need to work out what makes it work, but it is possible, and that's the kind of message I'd like to leave you with today. So sorry for everyone who asked a question that we weren't able to answer. We hope this conversation will continue, and you will get your answers, and thank you for making the time to join us.
Thank you.
Thank you.